So good morning, ladies and gentlemen. I too would like to thank the organisers for asking me to come and present today. And I'm going to present to you on optimal medical management in post-CABG patients. I'm Miles Behan. I'm a interventional cardiologist from Edinburgh. So what I'm going to talk about is, first of all, I'm going to tell you basically why is optimal medical therapy so important after bypass surgery, why it's often underutilised in bypass patients. Then I'm going to spend a bit of time just on what it actually is, why we should use it, how to increase the rates of it in your patients, and then my recommendations, which are in line with all the guidelines. So, it pains me to say it as an interventional cardiologist, but coronary artery bypass grafting is a very effective treatment for coronary artery disease in the appropriate patients. So, you've performed a fantastic operation, and once it is done, the trouble is that the patients are still at risk of going on to develop further native coronary disease or for degenerating their vein grafts with atherosclerosis or degenerative graft disease. So optimal medical therapy is very important because it goes on to maintain vessel and graft patency, it reduces recurrent events and the need for revascularization, and also it increases survival and improves quality of life. So it is incredibly important. However, we've seen that actually it is often underutilized, and it is underutilized in most bypass patients. Syntax, which was a trial, so patients normally are treated exceptionally well in trials, there they found that at the end of it, the prescription of optimal medical therapy, so that's one antiplatelet drug, a statin, beta blocker, and ACE inhibitor, only 41% of patients at the time of discharge were on that. And that's both in PCI and bypass. So the interventional cardiologists were as bad as the surgeons. And at 5 years, only a third of patients in both treatment arms are taking optimal medical therapy. So we're not good at getting patients onto it. And there's lots of reasons for this. One of the reasons is that there is this perception that, revascularization has occurred, job done, mission accomplished, you can stop taking the tablets. But that's actually very incorrect. It's exactly the opposite of the truth. Sometimes drugs, and we'll see some of them, are stopped when patients are admitted for their surgery, and then they're never quite restarted afterwards, and they're certainly not started on discharge. Compliance is a very difficult, multifactorial issue with lots of different things in it, but poor compliance is obviously an issue, is why people don't get onto it. And side effects. Patients aren't stupid. If you give them tablets which are going to cause side effects, if you're making men impotent because of their beta blockers, they just don't take them. So side effects are a very important thing. And also elderly patients, which are very represented amongst cardiac surgical patients, they also have particular issues with maintaining drug therapy. And just what is optimal medical therapy? So you know this, it's the antiplatelet agents, statins, beta blockers, ACE inhibitors, but also it's these measures like good blood pressure control, stopping smoking, cardiac rehab, and general lifestyle measures. And these are what's really important to keeping your patients well after the operation. So if we look first of all at aspirin. So aspirin has been around since 1900. It's been used since 1900 medically. It reduces mortality, MI, and stroke in coronary artery disease, and that's unequivocal. So it should be initiated at the diagnosis of coronary artery disease in all patients. And therefore, all patients undergoing bypass should be on an aspirin unless they've got some contraindication to it. And it's been shown that it definitely increases graft patency, particularly vein grafts at a year, decreases recurrent events in bypass patients post-surgery. There's probably an increased risk in minor bleeding, but overall it's safe. And then also it should be restarted early after surgery. And there's no doubt, if you look at these figures, if it started back within 48 hours post-op in this registry, there's a 68% reduction in post-op death, MI, and stroke. I mean, that is a very powerful effect. And also it's safe. There may be increased minor bleeds, but there's no major risk of increased hemorrhage, and there's no delayed wound healing, another important thing for you guys. And also, if we look at syntax data again, a lack of aspirin on prescription was the strongest predictor of death at 4 years in these patients. So aspirin is crucial. And that's why the AHA have come out with this very strong statement that aspirin should be administered preoperatively and within 6 hours of CABG in doses of, they use strange doses in the States, but 81 to 325 milligrams daily. It should be continued indefinitely to reduce graft occlusion and adverse cardiac events. So number one, patients should be on aspirin. But then we come on to the other antiplatelet agents, which are the P2Y12 receptor antagonists. These are the drugs clopidogrel, and the newer drugs, prasugrel and ticagrelor. And as interventional cardiologists, we use these the whole time. They work in a slightly different way to aspirin, and they prevent platelet aggregation. Dual antiplatelet therapy is aspirin and clopidogrel, and that's been tried in various trials, and it shows substantial benefits in people with MIs, acute coronary syndromes, and after angioplasty. In the original trial of aspirin versus aspirin and clopidogrel, the CURE trial, there was a subgroup of patients that went on to have revascularization with bypass surgery. And those patients then were looked at their outcomes. And actually, interestingly, there was a beneficial outcome if you were on aspirin and clopidogrel, and there was less bleeding in those patients in the clopidogrel arm. However, registry data has probably been a bit more realistic and shown a decrease in in-hospital mortality, patients operated with aspirin and clopidogrel, however, increased rates of bleeding. And then, do they have an effect on graft patency? Well, there's differing results from trials. One trial, however, found that, which had a predominance of off-pump patients, and we'll talk about those in a second, found no difference in overall graft patency, but a significant difference in vein graft patency. And a meta-analysis of 25,000 patients undergoing surgery on aspirin versus aspirin and clopidogrel did show a reduction in vein graft occlusion with dual antiplatelet therapy. And when we talk about off-pump, off-pump surgery has this benefit in the fact that there's less bleeding because there's a lack of platelet activation and consumption of clotting factors that you get when you put a patient on bypass. But interestingly, so this lack of bleeding means that, the tendency to bleed when you have an on-pump operation means that it's probably protective of early graft failure. So in some ways, having an off-pump operation, you're more hypercoagulable, so you're more at risk of early graft failure. And so therefore, it's recommended that actually DAPT is recommended following off-pump surgery, but for 1 year, to protect those grafts and prevent early failure. And we have our other P2Y12 antagonists, which I mentioned, prasugrel and ticagrelor. These are widely used now, probably more than clopidogrel, particularly in the UK, and they are powerful antiplatelet agents. But in the trials of these things where we looked at aspirin and clopidogrel versus aspirin and ticagrelor or aspirin and prasugrel, in the patients that went on to have bypass, there too was a benefit in the stronger agents. However, there was more bleeding, which is what you would expect. So overall, I think if we're looking at the P2Y12 receptor antagonist, aspirin we've accepted. If you can't take aspirin for some reason, clopidogrel is an effective, is a good alternative. If you have off-pump surgery, you should probably be on DAPT for 1 year. In patients who you are operating on who have recently had a stent or recently had myocardial infarction, then really after the surgery, they should complete their course of dual antiplatelet therapy, whether it's for 6 months intended or 1 year. And you can consider the use of DAPT in stable angina patients. The evidence may not be that strong, but it could be considered. So, antiplatelet agents, we're now moving on to statins. And this is a busy slide, which won't, but effectively this is patients, secondary prevention and primary prevention with statins. So secondary prevention, after the event has occurred, primary prevention, people that are just high risk. And you can see that the lower your LDL cholesterol becomes, the lack of cardiac events there are. And regardless of what you hear in the media, actually, statins probably are some of the safest drugs that have ever been made. They are not dangerous, and we have a 30 years experience of using them. So people with coronary artery disease should be on statins, but specifically in relation to bypass patients, high LDL levels particularly affect your vein grafts with this intimal hyperplasia and atheroma, as well as affecting your native coronary artery disease. Statins reduce this LDL, and they prevent vein graft disease, by reducing neointimal formation and the smooth muscle proliferation. And we can see that in one trial, the more aggressive you were at bringing down your LTL, the higher the dose of statins, the less your rate of vein graft occlusion at 4 years. And other smaller studies have confirmed that there is this benefit of being on a statin in terms of graft survival and future event rates. But also statins have these non-lipid effects. So they improve endothelial function, nitric oxide, and antioxidant activity. They prevent platelet aggregation. So given prior to surgery, they might prevent some of this, diminish some of this systemic response associated with surgery. And they have been shown to reduce the rates of AF and reduce the rates of renal failure, stroke, and mortality after surgery. So statins, I think, it's a no-brainer. But statins reduce LDL. There's also then evidence that if you can increase your HDL and decrease your triglycerides after surgery, that's a good thing. And unfortunately, HDL increase you can't really do that with tablets. And reducing your triglycerides is difficult to do with medications. Really, that's lifestyle measures. That's decreasing alcohol, increasing exercise, and a sort of healthy Mediterranean diet. So, unless contraindicated, all CABG patients should be started in the preoperative stage and restarted early after surgery. The higher intensity therapy you can get them on, the better, and they should not be discontinued pre or post surgery. So that's statins. Beta blockers are more difficult. I mean, these modulate the adrenergic nervous system. As cardiologists, we know they're very good treatment for angina, they're a very good treatment for heart failure, and they have this antiarrhythmic properties. Recently, data has suggested maybe that the fact that we have accepted them as so good, maybe their evidence on mortality benefit is not as clear as we thought it was. But generally, there is a belief that they're very good perioperatively at preventing mortality. They control the heart rate. They stop some of they definitely are a decrease in arrhythmias associated with patients being on them. And because of that, we would say that all bypass patients should be prescribed beta blockers perioperatively to prevent this postoperative AF, starting before surgery, and really they should remain on it after surgery for as long as possible. Bypass patients with previous MI should be prescribed beta blockers unless contraindicated, and also patients with LV dysfunction should be on beta blockers. So moving through, so far we've moved through, we've seen aspirin, clopidogrel, statins, and then beta blockers. And then we come on to ACE inhibitors, and these are these tablets which we all know that treat heart failure and hypertension. The problem with these around the time of bypass is that they do cause hypotension and increased inotrope requirements around the time of surgery. So they're normally discontinued. However, there are certain patients, it's very important to restart them as early as possible, so just after 48 hours. And those patients are the diabetics, people with previous heart attacks, LV dysfunction, and chronic kidney disease. The other ones who are probably on them just for hypertension, they can wait a bit longer to be restarted. But it's just so you want to start these patients as early as possible after surgery, but just be mindful of the side effects of hypotension and detriment to the renal impairment. And then there's additional measures. When you operate on someone, it brings home to them the severity of their condition, because it's a major thing to undergo bypass surgery. So it's a unique time to actually get them to change their lifestyles. And so we can encourage blood pressure control. The most important thing we can do is to try and get them to stop smoking. And you really have this opportunity to do that because they're in hospital for a period of time. Their diabetes management can be reviewed. All patients after surgery should be referred for cardiac rehabilitation. Dietary advice, you can change them from here to here. Flu vaccinations is important. And also depression screening. A third of patients who have bypass get depression. And those patients in that third who become depressed have much worse outcomes than the patients who don't become depressed. And simple intervention with either counseling or drug therapy can lift them out of that depression and stop those worse outcomes. So you're responsible for the whole patient and picking up these things. So how are you going to improve getting your patients on this optimal medical therapy? Well, so first of all, everybody has to remove this misconception that once you have your bypass or your stent, you don't need to take your tablets anymore. The exact converse is true. Before patients are sent home, there should be a checklist of what did you come in on, what are you going home on, when is the GP going to restart them. There's these programs like Get With the Guidelines, just to check your patients are actually on the right medication. Optimal medical therapy should be stressed at every medical encounter. So that's the follow-up visit to the surgeon, the visit to the cardiologist, the visit to the GP, the cardiac rehab, so that patients are aware that it's not just the physical thing of going through the operation, it's what happens afterwards. We should remove barriers. So in the UK, it's not such an issue, but the cost of medications or complex prescribing regimes, try and make things as simple as possible. And also then you can just monitor the results. I mean, if a patient's taking a statin, their cholesterol will be low. If they're taking a beta blocker, their heart rate will be low. If it's not, maybe they're not taking them. So my recommendations then for a patient who's had bypass surgery, I would want them definitely to be on aspirin, and you could consider them to be on clopidogrel as well, depending on whether they had recent acute coronary syndrome or it had been an off-pump operation. I'd like them to be on atorvastatin, because I think there's good evidence for this statin, at least 40 milligrams once a day. Normally we would have them at 80 milligrams once a day, but sometimes the higher doses do get side effects. Certainly around the time of the operation and until they're reviewed in clinic, I think they should be on a beta blocker. It will decrease their rates of developing atrial fibrillation and control them. Beta blockers do have side effects as time goes on, so maybe those can come off. And once they're on a beta blocker, you'd start them off at the lowest dose and aim for this heart rate of about 60 to 70 at rest. If they're on an ACE inhibitor, particularly if they've got LV impairment, diabetes, kidney disease, or previous heart attack, then it should be restarted at about 48 hours. Going forward, their blood pressure control, you want to aim for this magic figure of about 130 systolic. And if you're not achieving it with an ACE inhibitor, then diuretics or amlodipine, and that's important. Smoking cessation, good diabetes control. All patients should be seen in cardiac rehab. Cardiac surgical patients should have a flu vaccination. Now, we just sort of think that that's going to be taken care of by primary care, but it should be mentioned to them. And also, we do have to think about this depression screening, because that's major mortality or major morbidity after surgery. So just to finish, the take-home message from this is that although they've had a successful operation, the most important thing you can do for your patients really is optimal medical therapy, because you're going to maintain vessel and graft patency, you're going to reduce their recurrent events, and you're going to increase their survival and quality of life. Thank you.